Cognitive assessment and case formulation. Sharon is a 52-year-old single woman who worked as an information technology consultant for a large advertising firm. She had been employed with this firm for 10 years, and her job involved daily contact with a large number of employees who requested her assistance whenever they experienced problems with their computers. Thus, her job required many daily one-to-one interactions with individuals at their workstations dealing with their computer and network problems, as well as meetings with senior managers whenever there were questions about information technology. Sharon decided to finally seek treatment for what she described as a lifelong struggle with anxiety. She indicated that her main problem was heightened anxiety whenever she engaged in social interaction with work colleagues. She reported only mild anxiety outside the work setting and so never before considered treatment until 6 months ago when she experienced a significant increase in her work setting anxiety level. She declined pharmacotherapy from her family physician and instead agreed to see a psychologist for psychotherapy. Before offering Sharon a course of cognitive therapy, there were a number of questions about her anxiety that needed to be addressed. What was the nature of her anxiety disorder, and what were the primary anxiety symptoms? What external or internal cues triggered her anxiety? What were her automatic anxious thoughts and exaggerated appraisals of threat and personal vulnerability? Was she highly intolerant of anxiety and hypervigilant for certain symptoms of anxiety? How did she try to cope with her heightened anxiety? Were worry and avoidance prominent responses to anxiety? How did she interpret her failure to control anxiety? These are a few of the questions that were addressed during Sharon's assessment sessions that led to an individualized cognitive case formulation that is presented at the end of this chapter. Assessment and case formulation stand as a bridge between cognitive theory and treatment. Since its earliest inception, cognitive therapy has emphasized the importance of theory-guided assessment as the foundation for effective psychotherapy. In the first published cognitive therapy manual, Beck, Rush, Shaw, and Emery emphasized that diagnostic formulation, establishing treatment goals, educating the client into the cognitive model, and selecting target symptoms were critical elements in treatment for depression. The tools of assessment and case formulation that are now available to the cognitive therapist are much more precise than those available in the early years of cognitive therapy. For example, G.S. Beck developed a more detailed and refined cognitive case conceptualization scheme that can be applied to the anxiety disorders. She argues for the importance of conceptualization as a guide for focusing therapy on the critical problems and processes that underlie a psychological disturbance. Often treatment failure in difficult cases can be traced as a misguided or incomplete case conceptualization. Persons and colleagues provided one of the most comprehensive models for case formulation, emphasizing its individualized, theory-given, and hypothesis-generating nature. Cognitive behavioral treatment protocols for specific anxiety disorders like panic, social phobia, GAD, and OCD again emphasize the important role played by cognitive assessment and case formulation. Diagnostic and symptom assessment. The first 2 or 3 contact sessions should focus on assessment that leads to a preliminary case formulation. Diagnostic interviews. The diagnostic interview has always played an important role in cognitive therapy. Beck et al. Argued that a complete diagnostic evaluation is essential for establishing symptom targets and treatment planning. Although clinicians are divided on the importance of differential diagnosis in psychotherapy, there is no debate that critical clinical information is obtained in the course of conducting a diagnostic interview. A diagnostic interview is important to case conceptualization and treatment planning because it provides detailed information on the presenting symptom, typology, frequency, and severity. Key cognitive processes in the anxiety disorders are often assessed. Situational triggers and coping strategies, especially avoidance responses, are evaluated. Level of distress and impact on daily functioning is determined. Precipitating factors, symptom development, and course are delineated. Competing symptoms and other psychological processes that might complicate treatment are identified. 2 key questions must be settled before conducting a diagnostic assessment in cognitive therapy. It is really necessary to spend the extra time doing a structured or semi-structured clinical interview, or would a traditional unstructured interview suffice? Which is the best structured diagnostic for the anxiety disorders? Experts agree that structured or semi-structured interviews must be used to establish diagnostic status in clinical research. This is because structured interviews are significantly more accurate in determining a valid diagnosis than unstructured clinical interviews, and they have greater inter-rater reliability. Miller determined that the diagnostic imprecision of traditional unstructured clinical interviews was in large part due to incomplete data collection. Because semi-structured interviews force the clinician to assess all key diagnostic symptoms, this error in data collection is overcome.